So I want to welcome everyone. Good afternoon and welcome to SA Child and to this global listening and sharing session. My name is Gillian Saloojee and I'm the current chairperson of SA Child. Today, as we mark World CP Day, we have joined together with other academies around the globe as we share our experiences of building back better following COVID-19 and the lockdown. And I'm really happy in particular to welcome Jenny Carroll from the UK and Laura from Singapore for all the work that they've done in really setting up these global sessions. And both of them have been on marathon sessions, have really listened to a lot of the sessions today. So thank you so much for joining our session as well. As with all our SA Child webinars, the session's been recorded and it will be posted on our SA Child website as well as the RAACD website. So if you don't wish to be recorded, you just need to keep your video off and also then just rename yourself as a participant on your Zoom settings. So being in South Africa and Zimbabwe, load shedding and national blackouts are part of our scene, part of our environment. So in true SA style, we've done our best to prepare for the unexpected. So I myself have load shedding at the moment, and I'm using an internet, my Vodacom signal. So if that goes down, do not panic. I'm thinking of Louisa and Sitole in Zimbabwe. At any moment, they may also lose their signal, but do not panic. Do not panic. We will stay connected. The show will go on. We have got plan A, plan B, and plan C, and we will certainly be here for the next hour. It's really a delight to introduce you to our guests, to three of our guests this afternoon. Dani Schlesinger, Michaelow, is a speech therapist and audiologist who coordinates the Chris Hani Baragwanath Academic Hospital Cochlear Implant Program. She's worked at Barra for the past 13 years. Clinically, she works as both an audiologist and an oral rehabilitation therapist. She has attained her level 2 South African Sign Language certificate and has an honors in community psychology. She has a particular interest in family-centered intervention and working with multilingual families. Dr. Isaac Mulaudzi is a senior clinical manager at Siloam Hospital. He has a special interest in childhood disability in a rural area, and he's also a member of the Dartuni Village Daycare Center, and he is a parent of a child with CP. Thirdly, Dr. Louisa Mudawarima is a neurodevelopmental pediatrician from Zimbabwe. She works at the Children's Rehabilitation Unit at Harare Central Hospital and is a lecturer with the University of Zimbabwe College of Health Sciences. Louisa has a particular interest in the impact of cultural beliefs in the care-seeking behavior of families in Zimbabwe and believes more research is needed to explore cultural understanding of developmental disability and how to support families with affected children. In the second half of the session, Louisa will introduce us to Sitole and Yashanu, a specialist teacher and mum to 2 boys affected by autism. Sitole is the founder of Safe Haven Zimbabwe, which is a school for those affected by autism and related neurological disorder. So Sitole and some of the parents that she works with will be talking to Louisa in the second half of the program. So to begin with, we are going to, I'm going to hand over to Dani Schlesinger Michaelow. As I said, she's a speech therapist and audiologist at Chris Hani Baragwanath Hospital, and she's got a fascinating story to tell us about what has happened to their services as a result of the innovations they introduced during COVID-19. So I will stop sharing my screen and hand over to Dani.
Thanks very much, Gillian. Can you hear me okay?
Yes.
Okay, that means our generator's doing its job. Thanks, everybody. It's lovely to be here today. And it's really lovely to be part of such an initiative. I think it's really exciting. What I'm going to share with you today is just a little bit about the journey that we had at Chris Hani Baragwanath Academic Hospital in the context of COVID and how it shifted our services over the last 2.5 years. The service that I coordinate is the cochlear implant program at Barra, and being the only centre that's doing that in a very, very large area of several provinces, we have patients coming with very, very huge amounts of time in travel and huge barriers related to access that have been operated by since I started here. And I think we'd always seen that access barrier was one of the biggest barriers that we deal with in a public sector institution, where people have no choice. If they're going to access a cochlear implant, it has to be here at Barra if they're in this region. And so effectively many families are excluded from the service because of that distance. And I think that for a long time we had understood that we needed a different model of care. We aren't able to work in an outreach model away from the actual center, because this is where the equipment is. But we've sensed for a long time that looking at a telehealth option would really help us if we could help our patients access the service from a distance. But up until COVID, that was not a possibility. The HPCSA had not made provision for it, and our Department of Health had not made any provision for telehealth. So we had been refused that as an option. And so when COVID came along and we were told we could no longer see outpatients and our services all just stopped, we were able to get the relevant permissions to engage in telehealth for the first time. And so for us, it was unknown territory, but really exciting to suddenly have permission to look at other models of care. And there was a lot of skepticism about whether that could work in a public sector institution. Firstly, because we didn't have the infrastructure here. And second of all, because many of our patients come from environments where they don't have good cell phone signal, data, access to Wi-Fi, and those sorts of things. So we did a needs analysis with our patients, and we worked out which patients could access what form of telehealth. And within a month of the lockdown, we were actually able to move 100% of our speech therapy families of children with hearing loss onto telehealth, which was really exciting for us. And we spent that full lockdown period exploring what the different models were that we could offer and what could work with the different families. And it's just been astounding to us and how many changes it's allowed us to make that we've been able to maintain. So during the time when patients weren't coming in at all, we divided our telehealth services into a few different options. So the typical telehealth that I guess we mostly think of is synchronous sessions, where the family is on one side of the screen and we're on the other side of the screen, and we're working together with that family in real time. So for synchronous sessions, what we do is the family and therapist have a discussion prior to the session, usually on WhatsApp or telephonically, and decide on what their shared goals will be for that session. And then when they join the session, the caregiver engages in that activity with the child, knowing what the goals are, and then the therapist gives input during that session. So the parent might be playing with the child, the therapist is then able to coach the caregiver in additional strategies they might use in order to achieve what they're aiming for. And initially, we really were quite skeptical about if many of our families would take us up on it. But by the second year of COVID, it was 50% of our services. But there was still a big chunk of families that then couldn't access the synchronous sessions because of cell phone signal or issues of data. And so for them, we moved into an asynchronous model, which means that they would, again, set goals with the therapist in advance. Then they would film their child engaged in an activity with themselves and send that video across to the therapist. And then the therapist and parent would analyze that video afterwards, which wouldn't require data, because that could be done by a telephone, for example. And what that allowed is that a family, as long as they had a phone that could video, and I would say 99% of our families do have a smartphone for that, they would take the video and then they needed to find a way to get it to us. So what we did is we engaged in community mapping, where we looked to see where the free Wi-Fi spots were in each patient's community. So for example, a lot of the KFCs have free Wi-Fi. A lot of libraries have free Wi-Fi. So families would say on their way to work or on their way somewhere, somebody would take the phone and they would WhatsApp that video to us when they got to a free hotspot. And so that really works around the issues for us that we were struggling with in terms of the data cost. So during the lockdown period, we ran entirely through virtual services. And what we're offering now, that we've been allowed to go back to face-to-face, is we've offered families the choice of what package of care best suits you. And what's been really interesting is that we're still running about 50-50. So most families are saying, I'd like to come in for some sessions, but I can't come in for all sessions. So they're coming in once a month or maybe twice a month, and then they're having the additional sessions virtually. And what it's meant is that without increasing our staffing, we've actually been able to triple our attendances simply by improving that access. So we would have had, say set aside 5 hours to see patients, but maybe a couple wouldn't come in or somebody would run late because of transport issues or hospital bureaucracy issues. And now if a patient can't come in, we can just jump onto a virtual session with somebody else. And so we've been able to actually triple our attendances and maintain that for the last 2.5 years. And I think for us, it's just been amazing to see the opportunity that COVID gave us to move into a space that's really shifted the access that we can provide our families. We've done several surveys and focus groups to ask families about what do you prefer, what have been the barriers, what's worked for you, what hasn't worked for you. And I think what's been interesting is that 100% of families have felt that the telehealth option has really served them. Even those families who don't have access to the synchronous sessions, they've all found it extremely helpful. Many of them have said that the additional benefit is that the therapist is not in the room. And when we talk about ECI, we talk so much about empowering a parent to facilitate language, to facilitate learning. But I think sometimes when the therapist is in the room, we are more confident in something, and so sometimes we do it. And I think sometimes my presence may block a parent from giving something a go without me realizing it. And I think what we really found is that by being on the other side of a screen, the caregiver takes a much more driving role in the session. And so we've actually seen equal outcomes, if not improved outcomes, with many of our families. And those children who have multiple disabilities and are having to access 4 or 5 different aspects to their rehabilitation service are at least now accessing a portion of it from their homes. And so families are talking about the reduced burden to them financially and time-wise. Most of our families have said that the costs of data are less than the cost of transport to the hospital. So although data is not simple, it's still simpler than transport for most of the families. And I think as therapists, it's just really challenged us to think of creative, different ways that we can it can achieve what it's achieving in different ways. So we continue to offer individual therapy sessions, weekly sessions in that way. But we've also looked at things like our initial information taking, our case history taking interviews, and how if we actually have that initial contact telephonically with families, we've often gotten a much richer introduction to families because they often don't have their child with multiple needs in the room where they're worrying about keeping the child calm. And so we've been able to engage a caregiver and have conversations that maybe were harder to have in a big hospital building. And we've also run now a caregiver support group that we are now running via Zoom. And again, we had doubts about whether families were going to manage to access Zoom, and we prepared lots of materials, like little how-to handouts to explain to people how to download something or how to get on it. So we needed to prepare that material. But we run now a hybrid monthly support group, and 1 month is now done fully online and 1 month fully face-to-face. We found that the mix of that was not as easy. And so then we've got families from all over the country sharing with each other, and the group is facilitated by parents. And we've really seen that connection has been very, very powerful to be done where it's a parent at home, not having to manage again their child, but having that hour for themselves. We also have looked at creating telehealth materials, so educational videos that we've sent out, so that on a monthly basis, every week our families receive a different video with a how-to or a tip on language facilitation or on play. And I think those things have really augmented the sessions that we're offering. And so I think for us, yeah, COVID was just a really, really exciting opportunity. You know, they say every cloud has a silver lining, and I think we were very, very fortunate here that the silver lining of that difficult time has been something we've been able to sustain. Barriers are that we still have not received institutional support for the infrastructure that we need. So what this took was individuals who were willing to go the extra mile. So many of our therapists had uncapped data at home, and so they ran those sessions from home. We've now pulled together, so everyone pays something, and we have a router and Wi-Fi here in the department, but it's not yet supported at a hospital level financially. And we do see the limitations of that. And we are currently engaging our hospital management as an allied team with OT and physio and dietary and psychology to look at how we make this sustainable and how we make that infrastructure sustainable. We're also engaging with the telecommunication companies, trying to look at how to get the data costs decreased for the families that are accessing this. And there is lots of talk of models where potentially that could be made available either in data bundles or in particular codes that would allow patients to access that. So I think our biggest challenges, I think like for most of us, always remain a funding issue. But I think that in this case, it was not as hard as we expected to overcome the financial issues on our therapist side or our family side. With our current load shedding and huge numbers of hours where people are out of power, has an impact on our telehealth services, because families sometimes just haven't been able to charge their cell phones or just don't have signal. But what we've been able to do is we've had the flexibility to say, you don't have power now, we'll move your session. Okay, let's do an asynchronous session now for somebody else, and we'll run our synchronous session when you do have power. So because the whole structure has been flexible, we've been able to largely work around those challenges. So yeah, I think in closing, we've been fortunate enough to really find that this has given us a really lovely way to provide a range of care to patients, and definitely significantly increase the number of patients that we can reach. Thank you. I would be happy to answer any questions, or otherwise we can do that at the end.
Okay. Dani, that is quite inspirational. I think working in a low middle income country or in resource constrained settings, we often see barriers, and you have seen the opportunities and shown that it's possible despite significant challenges, particularly from the Health Professions Council in whether you are allowed to do telehealth, and from the hospital in that you had to use your own data. So I just think you've shown, if you have a team of really enthusiastic, committed people, how much you can achieve. And the fact that you have tripled attendances, and you've also done your focus groups to being able to show the evidence of that this new way of working is bringing results. Just thank you so much for sharing that. And I'm just going to ask everyone, we are planning to have a general discussion at the end of the session with Dani, Isaac, Louisa, Sitole, and the parents. But in the meantime, if you want to ask Dani any questions, please do use the chat line. So Dani, thank you.
Gillian, I do see a question on the chat. Should I respond to that now?
Yeah, sure.
Okay, so I see somebody asked if there's been a change in the time demand now that we've added telehealth. We've actually found that we have significantly more time. because in a sense, we had dead time within any day where a patient was late or being delayed in, we have horrendously long queues where a patient might do 2 hours for a stamp in the morning. All that dead time where a patient wasn't there, we can fit in an additional asynchronous session or a remote monitoring where we call in with the family and we check in. And so we're finding actually that we can get through more in less time. If that makes sense.
Okay. Dani, once again, thank you. And Dani will be online, so please do engage with her. And I'm going to introduce Isaac. And Isaac is both a parent and a medical doctor in a very remote hospital up in the northern part of our country in Limpopo, Siloam Hospital. And Isaac has got tremendous challenges with connection. So I just want to check, Isaac, are you with us? And can we hand over to
Yes, I'm with you.
Isaac, and the question that I have for you is to say, speaking your capacity as a father and also as a medical practitioner, how have services for children with disabilities attending Siloam Hospital changed since COVID and the lockdown? Have they changed or are they much the same? Thanks, Isaac.
Okay, thank you. And all protocol observed to the other colleagues. I will start talking as a father, then I will go on as a medical officer working in a rural hospital. COVID has affected a lot of families, especially for parents with child with disabilities, because number one, it was very difficult just to let your child go out, because we as a parent, we assume child with disability, the immunocompromised, just assume by looking at the disability, we associate the child with very low immunocompromise. We just assume the child can get sick anytime. But unfortunately, with those child, with my child per se, she have never got contacted with COVID while I was allowing her to play with others. But the main challenge was for the other children just to access health facilities, because there were restrictions in the public transport and restrictions in the hospital. Number of people were reduced that were seen per day. So that was the very, very main problem which we were experiencing. But since 2019, the beginning of COVID, all our clinics, the elective clinics for child with disability, especially the clinics that we run, it's a CP clinics, they were closed, trying to avoid the spreading of the infection. And while the clinics is closed, it gives difficulties to those parents, because now they are no longer getting trainings on how to take care of their child. It gives parents challenges. The equipment that we dishes or that we gave them as a hospital, they were not serviced, they were not even taken care of, because sometimes the child can gain weight. The equipment, for example, the bucket that we give to children, it becomes smaller, then it ends up hitting the child, because now the child is squeezed within the baggie. So that was the main challenge, because during COVID, most of the people, they were having poor access to health facilities, which since the restriction has been reduced, we can see the improvement at our side. Immediately when they reduce the restriction of COVID, that's where we started. We activate the CP clinic, we activate all the electives clinics so that they can re-see the patient, because patients were not properly seen during that time. But for now, patients are being seen properly, patients are having access to hospital, patients are having access to the malls. So it's a very serious challenge as a father to have a child like that, because we learn a lot of things. That way, most of the people, they learn responsibility. What I push, or I keep telling the parents on awareness that we have, is to introduce fathers, more especially the one who are on lower classes, to take care of their child. When they're taking their child to the hospital, I try to encourage the mothers who are bringing the child, so that sometimes the child can be brought by the father, so that we won't neglect these kids like it's for only the mothers. It's supposed to be, the support supposed to come from both parents if the child still has both parents. So that's the challenge that we were having, because it's only the mothers who are taking care of those children. We hardly see the fathers. Out of 20 to 50% that we can see, you find only one month in 12 months, one child come with the father. That's where the challenge is. It seems like we are pushing this disability to be the mother's disability, not the father's disability. But COVID has put a lot of things to the facilities. As I've mentioned, the supply for the assistant device was very low due to COVID. And now we having challenges even now to receive those devices. For example, the device that we get this side is the chair that they use, the mobile chair, the Madiba back. That's the most device that we issue to our patient. And we are not having the new back in our work. We keep on reservicing OT personnel. They are assisting us with reservicing those chairs. So for someone at the low class who don't have maybe finance to buy their own chair and whatever, it can be very difficult. And those chairs, when we assess, if they are not taken care of, most of the chairs are made of iron or zinc to a point. If they are not taken care of, the cushion on the chair is not well serviced, like what was happening during service, because during COVID, because there was no access to the hospital, they end up injuring the child. The child when is playing, the child when is sitting, trying to stretch, the child with stiffness, trying to stretch. If those chairs are not cushioned well, they end up injuring the child. So those were the serious challenge. The other challenge that we're having, the other kids, if we're not exposing our kids to other kids so that they can use to them that this is just a disability, but it's a human being that we need to play with. It's a human being that we need to interact with. So it's the thing that the other kids, when they see the kids with disability, that's where they will start to stigmatize. But we need to retrain the community about the kids with disability, that kids with disability, it's a human being. You need to play with the kids, even though just to push what we encourage mothers is to push their kids maybe on the playground where others are playing, while the kids is on the chair, the buggy, while the others playing. The minute you start laughing with others, it's like she enjoys playing with others. That's what we're trying to push. Yeah, COVID has put a lot of strain to the parents and to the hospitals. We are having a serious challenge again, even to reorganize the parents so that we can continue with the clinic. But we are working on that. And again, for being in rural communities, it's very difficult. Number one, we don't have access to public transport, for example, Uber. So if I'm planning to go out to expose my child to a mall or whatever, to take that child in a taxi, it's very difficult because the taxi, they don't understand these issues of leaving a space for a wheelchair or leaving a space for that Madiba buggy so that the kids can sit properly. So it's very, very difficult. That's why you find them mothers with those child, they have stress, most of them. We keep referring them to psychologists because they end up always putting their child on the back because they don't have access for those chairs that we give as the hospital to taxis or to the restaurant. But the other restaurant, they're trying to improve. If you can go to restaurant like Spare, they're trying to improve where they can improvise on the chairs. You can have a space where you can put that Madiba buggy so that we can welcome our child. They can have access to all activities that any normal child are having access to, rather than to restrict them due to their disability. Disability means something. I almost forgot this. In one of the speech that I did when we were closing the CP clinic last year, I tried to encourage the mothers that we agree they are getting that, but sometimes they need to spoil their child. The issue of taking their child out of the house to keep their child interacting with other people, it will help a lot, because some of the child, they are not attending the physios, the OT, but when it's playing with others, they get used to that play. They get used to those who can't even speak. They get used to the language that others speaking, to a point that you can recognize what the child is saying now. Just because the child is playing with others, they usually, when they're hungry, they will request food. Then she will get used to those languages to a point she can even give a sign to you that now my child is angry, rather than just to sit by the child when he's crying. I think that's all. Thank you.
Isaac, thank you so much. You have opened up so many questions there. I'm going to put some in the chat box for you. But in the interest of time, I am going to hand over to Louisa. So this is very special that we have our Zimbabwe team with us. So let me hand over to Louisa, who will introduce Sitole and the parents.
Thank you very much, Gillian. Welcome, everyone. So my name is Louisa Mudawarima, and I'm a developmental pediatrician from Harare, Zimbabwe, as Gillian has already introduced. But I would like to introduce my esteemed colleagues, parents of children who have different conditions, who have joined us today to talk to us about their experiences. First up is Mrs. Sitole, who is the mom of 2 children who have autism spectrum disorder. She's also the founder of Safe Haven, which has been supporting families of children who have disabilities over the years, and has also started an educational facility for children with autism and related developmental conditions. In addition, we also have Mr. Luke Pencil, and I'm not sure if Mrs. Pencil, if Mrs. Pauline Pencil is with you, who have joined us today. They also have a child who is on the autism spectrum, and they have worked hard to make strides in his development and to discover what his talents are. He enjoys music, I understand. And, you know, his parents have really delighted in the development that he's had over the years. We also had a couple of other colleagues who have had difficulty with networks, so are not here. As they join, we will introduce them. Okay. So I have a series of questions that I wanted to ask you, Sitole and Luke and Pauline, as family members of children who have disabilities, so that you can share your experience. I think I share a similar experience with what Dr. Isaac just described with running a unit for disability during the time of COVID. And I think, you know, we can all appreciate that it was difficult as practitioners, but at the same time, we never really got to hear the perspective of parents and to hear the perspective of and the perspective of how you want us to improve things as we go along. So my first question is to just ask you to describe the sort of extra needs that your children have at home. Sitole, you can go ahead. Sitole, you are muted. Let me try and unmute you.
Oh, sorry.
Yes.
Can you hear me now?
Yes.
Okay.
Please go ahead.
So I was saying I'm a mom of 2 boys affected by autism. The elder one is turning 19 and the younger one is turning 15. The elder one is mild, so I really don't have as many challenges as the younger one. The younger one was on the severe end of the spectrum, but now I think I can severely say he's now on the moderate. side. So the main challenges that have come with their condition is mainly on the routine part. They are so used to having things done in a certain way. So with COVID now, when it brought about the lockdown, you're not able to go to school. You now have to adapt to the new way of doing things, the new normal, the wearing of masks, the online lessons. That was quite a challenge for us.
And Mr. Pencil, can you briefly describe the extra needs that your child has?
Good afternoon, everyone. Yeah, our son is 15 and he's also autistic. The extra needs that our boy has got is that the major one really is the delayed language development. His language development is way behind his peers. So because of that, it tends to impact on his social interaction and also his behaviors, particularly when he feels that he's misunderstood or is failing to get his message across to the people that he's trying to communicate with. So his extra needs is particularly with helping him connect with the outer world. So you find that he's relatively comfortable with the immediate family, but then he's got serious challenges when it comes to the outer world. And that's the extra need that we've got. So, you know, when COVID came through, that was the biggest challenge because we needed to help him to connect to the world. At the same time, COVID was demanding that we be on lockdown. So in brief, I think that's what I can say for now.
Thank you, because both of you touched on how COVID impacted on your family. You know, and Sitole, you spoke a bit about the school closure and how those disrupted his routine as he is used to it, and how social interaction was disrupted for your child, Luke. So I'm going to move on to the next question, which is, if you had a magic wand, what would you have changed after the reopening post-COVID?
I think for me, maybe it's, before I get into that, it's important for me to share that currently I'm doing my master's in special education. So my dissertation was focusing on the experiences of parents on online lessons due to the COVID-19 lockdown. And one of the questions that I was discussing with different parents from different walks of life was, since COVID it seems to have come to an end, but it's very important for us to have a plan in place in case another pandemic comes again. We don't need to be caught unawares. And we've got our experiences that we had as parents, and I could identify and agree with most of the things that parents were saying. So my research showed that most of the children who were really affected were the ones who are moderate to severe, and I was focusing on autism. And it's important to note that the children with autism, they already have challenges on their plate already, without adding on to new things like you are now going to be learning online, you are now going to be doing things in a different way. So one of the recommendations, which I thought, which I agreed with, was I think it's very important for our Ministry of Education, Primary and Secondary Education, to come up with a plan where we don't completely do away with online lessons. Because as it is, for the 2 years, it was quite a hassle for those who are moderate to severe to really understand what was going on. So instead of saying everything is now okay, it may be a good idea for online lessons to happen, maybe do away with that. Because if another pandemic comes, say maybe in 5 years' time, it means the children would have already forgotten about how to go about doing online lessons. So that's one thing. Then given the close correlation between disabilities and the parents and the families that are affected by disabilities, the correlation of poverty and disabilities, it may also be a good idea for government, for our government to come in and maybe facilitate for all special needs families to get gadgets. Because for some parents, in as much as they wanted their children to take part in the online lessons, they didn't have the gadgets to do that. So on top of the gadgets, it may also be a good idea. I also could identify with what the first speaker said, the speech therapist, I think it's Dani, was talking about the cost of Wi-Fi and data. So there may also be need for provision of that to families that have got special needs children. And then close working together between the therapists and the teachers as well, so that parents are equipped. Maybe it could come up in I don't know, a training manual or something to equip parents for them to be able to help their children in carrying out these online lessons. But therapists will also need to be part of the team that is there to assist the parents. Because I'm sure, as you are aware, we can't talk of autism without therapies being put in place. So I think for now, that's what I can say.
Thank you, Sitole. And Mr. Pencil, do you have anything you'd like to add?
Yes, I would like to add a few points. I said something about our child being 15 and autistic. Our child, we decided to homeschool our child because we realized that that was the mode of learning that was appropriate, that was suitable to the kind of challenges that he's got. Because we tried some other avenues like conventional learning, like special needs schools, but we realized that homeschool was probably the best route for him. So when COVID came around, the educational front, on the educational front, our boy was not affected that much because if anything, he gained because the whole family joined him now, and the whole family could see to it that his academic journey was in progress. But where he suffered the most was on the social front, like I said, because since he is homeschooled, we are very much aware of the need for him to interact with the outer world. So when COVID closed us down, that's where we suffered because now we couldn't invite some peers to come over to the house to play with him. We couldn't take him to the horse riding lessons that he has once a week. We couldn't take him to the music lessons that he has once a week. We couldn't take him to the soccer and the basketball matches that we take him once every week. So COVID actually affected him significantly in as far as that is concerned. But coming back to your question, Louisa, about Magic Wand, we realized that whilst in our case, our child was benefiting on the academic front, he was coming short on the social front. He was benefiting on the educational front because we, as the caregivers, were ready for that. We were equipped. We had the equipment to see to it that he was that side was being addressed. Where we fell short was on the social front because we didn't have enough material to see to it that he is catered for socially. And so I realized that with my fellow parents that are in similar boats as we are, they had a challenge in that they did not have the material, or rather, how can I put it? They did not have the know-how in as far as pushing for the therapies for their children was concerned. Because now they couldn't go to the therapy rooms, so the therapy stopped. Now, because COVID had locked everyone down, so the child was suffering. The parents had no clue of what to do with the child. So if I had a magic wand, I think I would maybe advise the clinicians that they should have therapy following the child and the family.
Mm.
It sounds like you agree with him there, Sike.
Yes, I totally agree. I totally agree with him.
Because we realized that most of the parents were caught unaware, because you were used to just, maybe if you, like Dr. Isaac said, you struggle to take your child to the therapy room. And when you get there, you just stay outside and, the clinicians do whatever they do with your child, and then you take him back home. But then now, because of COVID, we were locked at home, and you had no clue of what exactly to do with your child. You had no idea of what to do with your child in as far as, maybe it was occupational therapy activities, or it was speech and language development, programs. You had absolutely no idea of what to do. So I would think that if the clinicians would make it a point that they develop home programs for parents, home programs, regardless of whether there's a COVID or not, there should be a home program that the caregiver is aware of, that the caregiver is very much a part of, so that in the event that we have a pandemic or there's a disturbance in the delivery of such services, then the primary caregiver can still continue with the child. Because I think that is where most of the parents fell short. And I think most of the children are affected because everything had stopped, and the people who were locked down together with each had no idea of what exactly to do with the child. So if I had the magic wand, I would say, if the clinicians would include the primary caregivers, particularly maybe have a file, open a file and have a file where the primary caregivers are very much following the proceedings. If it's issues to do with sensory issues, then they know what it is that they're doing, they know what they want to do, they know what they can do at home. If it's anything to do with speech development, then, things like that. If anything to do with physical activities, then they get to understand what they can do at home. I think if I had a magic wand, that's what I would have changed after reopening post-COVID. Thank you.
Thank you so much. To be honest, the time when COVID started was fraught with a lot of fear. And, with hindsight, I think it's fair to admit a lot of ignorance as well. On the one hand, I know that it felt for you as if you were isolated from the clinicians, but there's also a lot of wisdom that we glean from you as families and primary caregivers of children who have different needs. And, we were also isolated from that, and we also didn't know how to proceed. And I think what this is saying to me is that we probably need to have opportunities to sit down and exchange ideas. I remember before the pandemic, at some point in time, Pauline had invited me to come and see what was going on, but that didn't happen. And now I'm kind of regretting that, because that was an opportunity that could have possibly been useful in a future time. So that's very interesting. I'm going to move to the next slide, but realizing, of course, that we've already addressed some of the things and some of the questions on this next slide. So the idea is to, in our minds, craft the ideal services for the diagnostic process, the initiation of therapies and ongoing services and schooling for children who have, alternative needs. And I think Mr. Pencil did touch on this. Sihle, do you want to weigh in?
I think I could give maybe 2 pointers on the schooling bit, given that that's where I'm operating from. So yeah, I totally agree with what Mr. Pencil was saying in terms of equipping the parents for them to be able to work with their children whilst they are at home. And my experience has been, it's like 2 totally different worlds. When I was in South Africa with my younger son, we always used to get those home programs, and you would know what to do when you're at home, because after all, we, the parents, are the ones who do the bulk of the work. The therapists and other professionals, they only get to see my child for maybe 30, 45 minutes. That's if he's agreed to settle down and do whatever activities that are there. But the parents are the ones who carry the bulk of the work. And now coming back home here in Zim, it was a totally different thing. You as the parent have to come in and ask for a home program. That is not readily available. And sometimes when you ask for that, the therapists sometimes are taken aback. Maybe they think we are not aware of what we should be getting. They just think doing a therapy for 30 minutes and after the therapy is done, then that's it. So I think if the parents are involved in everything, all the sections that you've put in terms of diagnosis, if I, the parent, understand the diagnosis of my child and what it means for my child to have that particular diagnosis, then I'm better placed for me to be able to handle it. Initial therapies, and ongoing therapies that the child will require, parents are required to take part in that. Ongoing services, I think maybe that touches on the therapies that the child will be getting, the schooling bit, everything, all the services that the child needs to get access to. And then on the schooling as well, that is where most of the areas that need more attention really came out. Because whilst the Ministry of Primary and Secondary Education was saying we want each and every child to have access to their education, which is a right, by the way, the things that they put in place, like the radio lessons, really user-friendly for children who are in school. But for those like the Pencils and myself who were homeschooling our children, on that front, we didn't really face any challenges because this is something that we were already doing. But I'm just imagining another parent who was used to going in the morning, dropping off their child at school, and then coming back. They had the most challenges on that one.
Yeah, I agree that, online schooling was a frustrating experience for myself included. And I can imagine that if you have additional needs to take care of, it can be very challenging. Our last slide with questions is if there is a take home of where we can start as providers, can you provide 3 small steps that we can start with?
I think for me, what we can start with is the home programs. Those ones are very, very important. And also I've heard some parents who talk of sometimes the therapist saying, no, you need to be out whilst we are doing the therapy session. And I think that's not such a great idea. In as much as the child may give problems, I think the therapist should be there to be able to handle that situation, but the parent has to be involved in as much as possible. And even if the therapist is not able to provide a home program, but just the fact that the parent is able to observe what the therapist is doing, as well as giving feedback and giving information. We are doing this activity because we are trying to address 1, 2, 3. The parent will be better placed to be able to help their child whilst they are at home. And there needs to be that close working together between the therapist, the school, and home.
Mr. Pencil, what would you weigh in on this last slide?
Yeah, I concur with what Sitole is saying, basically, because I'm of the view that particularly the initial assessment is key for me, because I think it has to be very comprehensive, and so that there is a thorough establishment of the child's baseline, so to speak, where the child is in terms of his abilities, his capabilities, his challenges, and so on. And I think sometimes I don't know, but the many times that I've gone to many therapists, I felt that there was a missing point somewhere where the assessment started and ended in the therapy room. I think that if you want to have a better understanding of my child, it would be best to organize assessment in the child's natural environment, that is at home. And if the child is going to school, and maybe there's need for the clinicians, if possible, to assess the child in that environment also. And then maybe assess the child in a play center, and finally maybe in the therapy room where the parent or the caregiver is answering questions, is giving much more information to the clinicians. If the assessment starts and ends in the therapy room, I feel that there's a lot of stuff that gets missing in there. I don't know if it's practically possible, but that's what I think. I'm thinking that, for instance, we are just talking about COVID here. Imagine a scenario like this. If you come to my home to assess my child, and you probably say, okay, fine. During some other days when the child is not coming to the clinic, I noticed that there is this thing here in your yard. You can use it for A, B, C, D. That way your child will be benefiting in X, Y, Z. In that regard, then you are helping the child and you are helping us also as parents. So I'm thinking that the initial assessment has to be thorough. And then, like Sitole said, engagement, close engagement with the caregiver. I like what Dr. Isaac said earlier on, that in most cases, the fathers are missing in action when it comes to disability. I think that the clinicians also owe it to the family to explain clearly the demands of disability to the family. That you cannot expect your child to be included elsewhere when you as a family have not included him in your lives. Because the very fact that you've got a child who's got a challenge, who's got extra needs, demands that it demands that you as a family, life is no longer the usual. Life has taken a twist, and therefore you have to include him. So I think I've tended to notice that caregivers tend to respect clinicians a lot. They respect your insight, they respect your advice. So if you take it upon yourself to engage the caregivers and advise on the challenges that are at hand, maybe, just maybe, the fathers can come on board and the whole family can help, particularly the mothers. And then finally, I think connecting with the concerned child. I've been to instances where you walk into the therapy room and the therapist has forgotten the name of your child, has forgotten where he was, has forgotten what he or she is capable of doing.
So, I'm thinking that if the clinicians can actually connect with the concerned child, it can help in their delivery of the whatever services that they are delivering, and I think it will help in the general health of the child at the end of the day. Thank you.
Thank you very much. So it looks like we are at the top of the hour. I will stop screen sharing and move to full screen. We had made allowance for a few minutes to talk, but I think hearing these opinions was really, really important. And I think what I've learned is the dialogue is really necessary. I think the other thing that we can try and employ is the strategy that Dani and her team used, where some of these things can happen asynchronously. So if you're noticing particular behaviors or things that are happening, maybe recording some of these things so that it's not necessarily that we're having to come and assess them in real time. We can make other time arrangements in order to see what is going on with a particular behavior or, action and advise or input on it. That may be a way of getting around some of the challenges. I think, assessment and therapy in a resource-limited setting, such as the one that we have, often falls short of what we're trying to aim for. And it's important for our caregivers to hold us to the standard that we need to be held. Thank you.
Okay. And from our side, thank you, everyone. I want in particular to thank the parents that have participated in the session. I think, as Louisa said, we need far more of this dialogue, and that's what these sessions are all about, listening and sharing. And so I just want to thank everyone. And I also, just as Mr. Pencil was speaking, kind of linking that kind of went all the way back to what Dani, our first speaker, was saying, in that it's only through videos that therapists really began to see what was happening in the home setting. So, it's not an either or, but how can we make use of videos, particularly when therapists may not have the time to go and do home visits in school settings. And as Mr. Pencil says, it's absolutely critical. You want to see the child in his own environment. I think we have one last comment from Isaac, and then we shall close off. Isaac. Isaac, you're on mute, and I see your hand is up.
Yes, you can hear me now.
Yes.
I think on the last slide that was presented, when they were talking about schools and parenting, it comes to my mind that mostly the area where I am now, in Limpopo, deep rural, for example, we don't have school for child with disability. More example, child with CP, child with autism. We end up, I can't even explain, because we're having a challenge. When I was looking for a school for my child, I have to drive all the way to Pretoria. You say I need to take my child to the school at Pretoria. Not that we can take care of the child at home, just for the child to interact, to learn some few skills from school. We agree the child might be CP, but there are few things that the child can learn if we have school in the areas. But it comes to my mind, for me to travel every weekend, every Sunday, to take her to school, take her back on Friday, because the school closed on Friday, we need to take the child back. Then we end up getting one school, which the school, I think it doesn't have support from mostly the public sector or private sector, because there was a time where they were planning a trip. They even failed to plan a trip because of financial constraint, and the school was closed during COVID. It's very difficult. Trying to answer that question, 3 little steps that we can start. When I'm sitting here, I'm even thinking now, no, we don't have schools here. We need to think abroad. Rural areas must have school for child with CP, not more of private, more of public, where public will participate. Those child, as the Bill of Rights, it says every child has a right to education. It depends what education. If the child needs special education, we need to have a special school as much as we have Chilidzini special school for deaf and blind and whatever. How about those child with CP and whatever? Thank you.
Isaac, thank you for leaving us with that challenge and for just reminding us. Yes, we may have made quite a lot of progress, but gee, we are only at the start of it. There's a long way to go before all children with disabilities can realize all the rights that they're entitled to, whether that's therapy or education. And I just want to thank everyone once again for joining us at the session. I want to thank Laura and Jenny for their help in organizing this global session. And said the session will be on the website. And I just really want to thank the parents for sharing your insights. There's so much that we can take forward from this, and I do hope we can continue the conversation. Thank you all so much. Bye.